Hello dears, President, colleague and Director of the conference. I am Dr. Fathi Nasra, Professor of Neurology at Al-Azhar University, Cairo, Egypt. I will deliver my talk about the value of recanalization in acute ischemic stroke. As we know, many aspects of stroke have been extensively studied. The prognosis of acute ischemic stroke is one of these aspects. Also, many studies directed to early spontaneous or induced, artificial recanalization by using thrombolytic therapy rely on early restoring of blood flow. Spontaneous improvement occur mostly during the first 6 hours. The presence of hyperemia due to collateral blood supply may lead to dissolving of clot by intrinsic thrombolytic mechanism. Reopening occurs more in younger patients, non-diabetic, non-hypertensive. Early reperfusion is followed by good clinical outcome. As we know, reperfusion occurs more in cardioembolic than in other causes of embolism. Digital subtraction angiography used to determine the presence of abnormalities in both intra and extracranial vessels. In the first hours following stroke, cerebral artery occlusion and recanalization can be demonstrated by using these tools. There are two: partial occlusion or complete occlusion. Partial occlusion means passage of dye vessel to the obstruction, but complete restoration of flow was defined as passage of contrast both to the previous one of obstruction with normal blood flow. Aim of this study is to evaluate the prognostic value of early recanalization in acute ischemic stroke by using cerebral angiography in correlation with clinical outcome and CT brain findings. This study was conducted on 16 patients from 50 patients who came to the emergency department of Al-Azhar University hospitals. All patients included in the study came within 6 to 8 hours from stroke onset. Inclusion criteria: all patients with acute ischemic stroke, age greater than 18 years. Exclusion criteria: patient with cerebral hemorrhage, all patients excluded from thrombolysis if indicated. All selected patients were subjected to the following: complete general and neurological examination. Neurological examination including National Institute of Health Stroke Scale. Computed tomography have been done first to exclude patients presenting with intracerebral hemorrhage. Complete lab. Echocardiography, duplex, cerebral angiography at the first 8 to 6 hours of admission to detect the site of occlusion, and RTBA injection in appropriate cases, and repeated angiography after 24 hours to detect early recanalization. As we know, if there is good collateral, means good spontaneous recanalization. If no good collateral, we need artificial recanalization by intraarterial RTBA. As we show this is thrombus and penumbra and collateral flow. If good collateral flow means dissolving of the clot by intrinsic thrombolytic. If there is no collateral, or does mean no hyperemia, it means complete stroke or occlusion, and this needs artificial recanalization. All study group were 16 patients, of whom male were 9 and female were 7. Diabetic and hypertension 7 patients, hypertensive 2 patients, and ischemic heart disease 1 patient, rheumatic heart disease 4 patients, and diabetic 1 patient, unknown 1 patient. The studied patient were classified into two groups according to the outcome. Group 1, spontaneous recanalization, and Group 2, induced recanalization. That means needs intraarterial recanalization by thrombolytic. There is no comparison of sex distribution with outcome. This table shows no statistically significant difference in sex, and this table shows no statistically significant difference in sex distribution as regarding outcome. And this comparison of rheumatic heart disease gave a good result than other disease. And this is consciousness. If the patient presenting the first with intact consciousness or good consciousness, that means good outcome. If there is any disturbance of consciousness, this means bad outcome. Comparison of CT finding. If there is a free CT scan at the first of admission, this means good outcome. Comparison of angiographic finding with outcome. Show this statistically significant difference in angiographic finding and writing outcome. If there is complete occlusion, this is bad outcome. Partial or spontaneous recanalization is good outcome. And this type of treatment, we in the first day injected intraarterial TBA, and after 24 hours we injected low molecular heparin. Cardiac duplex finding, patient with free duplex, that means no occlusion intra or extracranial, give out good outcome. And diabetic mellitus, diabetes and hypertensive give bad outcome. As regarding age, young age gave good outcome and elderly gave bad outcome. And the male patient, this is one of our cases. I will illustrate two cases. The first case is male patient, 45 years old, diabetic, hypertensive, ischemic stroke, right side weakness, and this is 120-minute duration. Exercise 10 before treatment with thrombolytic therapy, and after 140 minutes show normal CT scan finding. Digital subtraction before treatment with thrombolytic therapy, and after 150 minutes show occlusion of left middle cerebral artery as we show. Digital subtraction after treatment with thrombolytic therapy and after 24 hours show recanalization of left middle cerebral artery. So the first day was occlusion of the left middle cerebral artery, and after intra-arterial RTBA, and we have done angiography after 24 hours show complete recanalization after injection of RTBA. Exit CT after treatment with thrombolytic therapy after 24 hours show left temporoparietal infarction. And this is case 2, female patient 50 years old, presenting with acute ischemic stroke, right-sided weakness, 90-minute duration. CT brain before treatment and after 110 minutes show normal CT scan brain. And digital subtraction angiography before treatment and after 120 minutes show no occlusion of left middle cerebral artery. CT brain after treatment with low molecular weight heparin after 24 hours show left posterior capsular infarction. Conclusion. There was statistically significant difference in angiographic finding as regard outcome and the higher frequency of recanalization among good outcome, while there was no statistically significant difference in type of treatment as regarding outcome, but there was statistically significant difference in time of onset of stroke and initiation of treatment as regard outcome, as we found higher frequency of late onset among bad outcome. So we need early, this is all the time window. So if we are seeing the patient early, we get good outcome. lower NIHSS score among group 1 than group 2 in all follow-up measure, first day, second day, 1 week, 1 month, 2 months, 3 months, and the difference in between was statistically higher significance for 1 week, then significance for 1 month, 2 months, and not statistically significant difference in the following 3 months. Recommendation: patient with stroke and no documented angiographic occlusion must be withdrawn from thrombolytic therapy. So this is mandatory angiography. Introduction of non-invasive technique to assess recanalization may improve patient selection. Spontaneous recanalization can result in several important consequences, and therefore the patient who has spontaneous recanalization is better to withdraw from thrombolytic trial and so avoid the hazards of medication. That's me. If you are done artificial or if there is spontaneous recanalization, this patient doesn't need for thrombolytic therapy. Cerebral angiography may be done for ischemic stroke patients who are candidate for thrombolytic therapy to avoid unnecessary use, complication, and cost of therapy. Media communication like TV must instruct the people about early signs of stroke and how to deal with this patient, and this should be known by the general population. Stroke center must be available for all stroke patients to be reached easily and quickly. Teamwork consists of radiologist, neurologist must be available for good selection therapy, for thrombolytic therapy, and intra-arterial injection. Angiography may give false negative result, small penetrating artery, or false attributing vessels. So, we can conclude that we should know the early intervention with patient with acute ischemic stroke is more better than the late intervention. So this need propaganda and announcing for the first symptom and sign for the patient and for the surrounding and through the media to avoid the hazards of complete infarction and the disability. And this is our aim of this study. Thank you indeed.